We're live now, Chair.
Thank you very much. Good afternoon, everybody, for colleagues on the gallery online, but for anybody who is taking the time to join us either live or watching a later recording. A very warm welcome to the October meeting of the Wye Valley Trust Board. Those of people who've joined previously will recognise that I'm not Russell Hardy, who is our chairman. Colleagues may know that since the expansion of our foundation group to include colleagues from Worcestershire Acute Hospitals NHS Trust, we have agreed a slightly different format for our annual board cycle. So once a quarter, Russell will continue to chair our board, ably supported by Glenn Burley, our chief executive. On another month, we will meet as a foundation group and do encourage people who don't understand what that is to join the group. It gives us an opportunity to share and learn with colleagues across our wider family. And on the third month, every quarter, I will be chairing as deputy chair, supported by Jane Ives, our managing director. So this is the first of this structure, and very keen that we continue to provide local scrutiny, accountability and access for the people of Herefordshire and Powys to be assured of the services that we're providing on your behalf. It gives me particular pleasure today to welcome Dr. Chizu Agwu, who is a consultant paediatrician, currently Deputy Chief Medical Officer at Samwell and West Birmingham Trust, and Chizu will be joining us as our Chief Medical Officer later on this month, when we say au revoir to Mr. David Mowbray, who is our very able and current Chief Medical Officer, who will be leaving us to take up a role within the foundation group. So we're not losing David altogether, and we'll say a few words about David's contribution at the end of the meeting, not wanting to make you at all anxious, David. Also, another board change to make you aware of, Andrew Cottam, who has been one of our non-executive directors for 2 terms of office, left the board at the end of September, and delighted to welcome Sharon Hill, who has been one of our associate NEDs since the beginning of July, to take up a role as non-executive director. So welcome to the board with a slightly different hat on, Sharon. So a continuity, and one of the things that we do is to enable us to use our the recruitment process for associate NEDs to build a pipeline of people to take up the full responsibility. We have a few apologies for the meeting today. So in addition to Russell and Glenn, also John Barnes and Joe Rouse, one of our non-executive directors, isn't able to be with us today. Have I missed any apologies, Val?
No, that's correct.
Lovely, thank you. Has anybody got any declarations of interest to declare that are new for this meeting? No. Silence is good. So as usual, we will start with one of the most gratifying parts of our board responsibilities, which is to say some thank yous and well done. So included in the pack of papers, you will see within the Chief Executive's report the extra mile awards for June and July this year. So I will try and give credit and appropriate recognition for colleagues. So the team of the month for June this year: Emma Cook and Robin Evans. Emma and Robin have supported the recruitment team by managing 2 divisions within Wye Valley Trust because of staff shortages. Emma first started her role with KPIs of 20%, however worked so hard with determination and dedication that she reached her KPIs within the 80s. Her human resources business partners are impressed with Robin and her strive for excellence within her role. Emma's also recently feedback from senior managers in the trust, thanking her for her patience, support and advice during their recruitment process. Emma's doing a brilliant job and shows her dedication and amazing work ethic. Emma and Robin have and continue to do a brilliant job and should be extremely proud of themselves and how they came in their roles. So many congratulations and thank you from the whole board. You'll get some ripples and some on-screen applause, but many thanks from all of us. The Employee of the Month for June this year is Lauren Austin, and this is a really great commendation. Lauren cared for me on and off whilst I had my stay on Y ward. Yet again, for me, this was another stressful stay. I had no idea what was going on and kind of just had to go with the flow. Lauren was always calm, reassuring, and a friendly face when I came back round. Lauren went above and beyond just so that I could have a little privacy and dignity when being observed due to my other symptoms and needs. She's very calm in some very trying situations. She's friendly, helpful, and empathetic, and really needs to be acknowledged. She has my total admiration. Please don't stop at being a healthcare assistant. You will go far. So many congratulations to Lauren, a shining example of the embodiment of our trust values, and a credit. Claire. No? Oh, you
Sorry, press the wrong button.
So it was applause, not a hands up. We will take that. Employee of the Month for July, Sophie Whedon. Due to the clinical lead resigning, there was a major gap in the authorisation of results. Sophie worked tirelessly with Dr. Rees to refine a procedure for authorising results, which was based on a clinical algorithm. Sophie led on a procedure to audit this new system to ensure it was clinically safe, carried out the audit and discussed the issues with Dr. Rees to refine the new system. She wrote her own training records, which were signed off by Dr. Rees, and has now started cascade training to other staff. Sophie has demonstrated a brilliant grasp of what is required to maintain a high quality service, shown she's gained, she apply her knowledge in a logical manner and an understanding of what is within and what is outside her scope of practice. Many congratulations, Sophie. And by no means least, the Team of the Month for July, the Acute Medical Unit, Ashgrove MDT, Samantha and James Bartlett. I want to acknowledge the dedication, compassion and excellent care provided to a young lady who I referred to as R by the whole teams on AMU and Ashgrove, and with continuity of care provided by Dr. James Bartlett. They were all able to deal with a challenging patient who threatens due to being distressed, and enabled discharge to a new care home, which R is now loving. Both teams on AMU and Ashgrove and Dr. Bartlett to be acknowledged for their dedication, commitment and compassion in keeping R and others safe in hospital, and the exemplary example of personalised care planning. So thank you very much to the teams and AMU and Ashgrove. Sarah.
Yeah, just to acknowledge James hasn't been able to attend today, so we'll relay it back to him. Thank you.
And I'm sure he will watch it all endlessly on YouTube. So thank you, Sarah, and to all of your colleagues. Will you pass on thanks from the board? Thank you for making the time to be here this afternoon. Understand why people with clinical commitments can't fit around our board schedule. So thank you for being here.
Lovely. Thank you very much.
Thanks, Sarah. Okay, so moving to the business section of the meeting, the minutes of the meeting held on the 7th of September. Has anybody got any issues of accuracy that they would like to raise? I will take silence as assent that they're a true and accurate record. Thank you, Val. The matters arising, which are on page 20 of the pack. One for you, Jeffrey, about the staff survey, and that is on the agenda for later in the meeting. Katie, the Chief Finance Officer, to review the difference in plan provision for inflation and actual, and you've indicated that be available from month 6. Yep, so we'll look forward to that in due course. Thank you, Katie. And for Andy, Chief Operating Officer, include more information on bed occupancy and patients medically fit for discharge, and you'll pick that up as part of the IPR later, Andy. Thank you. And then one for Erica. Colleagues will remember we had a presentation about the Armed Forces Covenant last time. And Erica, would you like to update us on the process for patients and families who don't wish to have recorded that they work for or within the forces?
I'm still taking advice, Chair, from regional colleagues and establishing what best practice is.
Thank you. It's a very important item that we discussed in length last time, so look forward to an update of that in due course. Thank you. Okay, so sorry, Erica. Sorry. Okay. Moving on then to item 5, items for review and assurance. And Jane, without Glenn, the mantle falls for you, please, to highlight any issues from his report. Thank you.
Yes, thank you. So Glenn's paper really provides more of that sort of national perspective of what's going on. So I thought I'd pick out sort of some of the more local implications of the things that he's highlighted. So firstly, around outpatient transformation, I think it's fair to say that we've gained an awful lot by being part of the Further Faster initiative, linking into the Getting It Right First Time work that's been going on for some time. And all of the pathways that Glenn mentions, I mean, we're pursuing those across the piece. And certainly in terms of PIFU, that patient-initiated follow-up pathway. So patients, instead of calling them back to a regular outpatient follow-up appointment, we put the authority in the hand of the patient to say, actually, you tell us when you need to be seen, and then we will see you quickly. And what we've found with that is that patients generally need to be seen less often when they're in charge of their own pathway. So our national target on that was 5% across all of our pathways. And we've got our most recent data, we've got to 4%. So we're really making good progress on that. But of course, specialty by specialty, that's quite different. So some specialties, that's 20% of patients are going on to a PIFU pathway, and others, it's none at all because of the nature of the different specialty. But we're making really good progress. One of the things that's really helped with that is what's been developed through this national programme that we've been part of. Are things called playbooks. So specialty by specialty, there is a set of best practice advice and benchmarks, national benchmarks, which we're scoring all our specialties against, and they're looking at those and seeing what they can implement, and that is really starting to do things at more of a pace. And it is really very closely aligned with the work that David Mowbray has been leading across the group, and again that was an initiative that was called PACE, and it's fair to say, David, it was difficult to get off the ground because this needs an awful lot of work in the background to pull all of these benchmarks together. So there's something about adopting the principles that we were already working on, but the scale of being able to do it nationally and the resources that nationally are available. I mean, it really has meant that we've been able to accelerate all of that work. So that's been very much a positive for us to be involved in the initial pilot stages and one of the first organisations to go. The other thing that Glenn then mentions is the integration front runner, which is some work that South Warwickshire is doing, and again is part of a national pilot on that. And you will see from the report there are some really impressive results of how long it is taking to discharge patients who need to be cared for at home, and we know that's a particular problem in Herefordshire, where access to that, what we call pathway 1, or support at home, has been limited by the availability of capacity. So obviously, as part of the group, we've already been linking into that work, and Becky, who leads on that work in Warwickshire, has been to a number of workshops locally. And the asset that we have, which is Hoople, which is a company, but it's owned completely by the council and ourselves and the ICB, is a vehicle where we can rapidly replicate, I think, that sort of work. So the opportunity that we've got through the Better Care Fund, which we'll be talking about later on the agenda, I think means that we can start to replicate that sort of model reasonably quickly in Herefordshire, but I think probably not quickly enough for the winter. But again, it's that learning from best practice and being able to implement quickly. Last point that Glenn makes is around NHS finances, which is obviously a difficult place at month 5, with the whole of the NHS around £800 million. In a worse position than they expected to be. The proportion of that that's with RICB is about 9 million. So whilst off target, we are not as off target as the rest of the NHS, and the same for ourselves here at Wye Valley. We're about £1 million off target, which Katie's report comes to later. So not where we want to be, but comparatively not a very bad place across the NHS. There's the usual things from the surgical division there, which you'll be able to read. Only one I wanted to highlight there, which was around the surgical robot. The adoption of this new technology has been really rapid in here in the trust, and we've got 3 specialties that are now active with that after going through their training. So that's really quick adoption from when it came on site, which I think was in April when it actually arrived. And we've also now agreed that radical prostatectomies, which currently for our Herefordshire patients are done in Cheltenham, will now be able to be done here locally at the trust. So a real benefit for patients to have local treatment, but with the same surgeon who would have operated them in Cheltenham, who's one of our urology surgeons here, and he's actually led all of the work. So so a grateful thank you to Mahmood Akhtar. So those are the things I wanted to raise in terms of the more local flavour, but happy to take any questions.
Thank you, Jane, very much. Questions and comments for Jane? Ian.
Yeah, thank you, Jane. Some really interesting things there in the report. I wanted to pick up on the really impressive results in domiciliary care waiting times in Warwickshire, and that's a tremendous result in terms of reducing those, and glad that we can look at introducing that in Herefordshire. The bit I was interested in is that the underlying issue for social care, and particularly for domiciliary care, tends to be lack of resources for domiciliary care providers to invest and recruit sustainable workforce. And I was really interested in the extent to which Warwickshire have been able to improve things through better processes, or have they had to put additional funding in as well, and how would that impact on us in Herefordshire?
I think it's both. It's certainly better and slicker processes, and we know we've still got a lot more work to do in terms of making our process for patients much slicker than it currently is, and so that's the work that's going on through the discharge to assess board. I think it's different investment. I think there probably is a little more, but I think it's different investment. It's around access to an arrangement with domiciliary care providers who are on standby. So the funding allows them to run with vacant capacity, so they've always got capacity. So I think that's where the resources come in. I think we do have a more difficult recruitment market here, so it's not that we can pick up that model and move it here and then it will all be better. But I do think that the work that we've already done with Hoople, who provide home care, I think is a basis for that, and I think we can take that a lot further and use that opportunity to fill in some of the gaps where we know that the local home care market is not able to fill those gaps, particularly in our very rural and remote areas. So I think there is an opportunity for replicate it, but I think ultimately it will need some resources as well.
Thank you. Thank you very much. Do you want to come back in, Ian, or is that a legacy hand? Okay, thank you. Thank you, Jane. Really comprehensive as ever, and just wanted to we've said thank you to the whole team for the implementation of the surgical robot several times in the last few weeks. But I think one of the things that we're particularly proud of, as well as the direct impact on patients in terms of shorter recovery times and reduced travelling, is the impact that it is having on recruitment and retention of staff. So that's a really important thing for patients of the future. So well done for everybody with that. Okay, moving on. So Jane, integrated performance report.
Thank you. So just a few comments to kick us off. So I did suggest at the beginning of the summer we need to make hay whilst the sun shone. Well, the sun didn't shine very much, but I think we have made a lot of progress in improvement, and actually all of that going further faster work is very much part of that. But at the same time, we have been managing the strike action across the summer and this week has been the most impactful of all of the strike action that we've seen, as it's been coordinated at the same time. Consultants and junior doctors and radiographers on Tuesday have been taking industrial action. When I wrote this report on Thursday, this was the position that we were only at that stage able to run 4 of our 10 planned cancer lists, and I think that's quite distressing. It's certainly distressing for patients who know they've got a tumour and they want to go to surgery and they want to have it removed. We have worked with our teams over the course of this week, with David Mowbray in particular, making some more direct appeals, and we have now been able to run 8 of those 10 lists in this 3 days. So in the end, we only lost 2 lists, but that is extremely difficult for those individuals involved. We can only hope that this action is going to get resolved in the near future, because it is certainly very damaging. I'm going to talk a few other things then. So I've talked about the GIRF work and the outpatient transformation, but our elective productivity work is continuing, and there's a measure called value weighted activity, which looks at the amount of work that we're doing and its complexity, and compares it to our benchmark, which is 2019-20, before the pandemic. And again, I've just had the latest data. I put in the report that we were running at about 115%, which is the best in the region of the whole of the Midlands. And actually, we're now at 120%. I'm sure this week will have been significantly below that for the reasons that I've already alluded to. But that's a really good result from our teams. We're doing 20% more work than we were in 2019-2020, which is exactly where we want to be. Want to talk a little bit about our people metrics, because again, they stay in a much improved position and are maintaining that position, and some fantastic work over the course of the summer from Jeffrey and his team, going out, doing the In Touch campaign, which touched hundreds of our staff actually, and getting their feedback, and Jeffrey will talk a bit more about that later. And then last thing I wanted to end on was our SHIMI. So our standardised hospital mortality indices, which when I arrived in the organisation nearly 7 years ago, was running at 125, and the standard is 100, and our latest figures is 101.8. So and 100 is the benchmark. So we are very much within the expected level. That only goes up to I think that's April, May of this year. David, you'll probably tell us more when you get to your report. So by the time we get to October's figure, it may well be that we'll have dropped to 100. And I just wanted to pay a personal tribute to David, because his leadership of this has been absolutely exemplary, and is the reason why we've seen that level of improvement. So a big thank you from me, David.
And completely echoed by the whole board. So thank you for that, Jane. So are we moving on? The helpful update. Any particular questions that anybody wants to pick up with Jane, or should we go straight into the director reports? Okay, so Lucy, David.
Thank you, Chair. Purposefully light from my perspective in the quality indicators report this month, and that's because we've got detailed reports around patient experience, patient safety and infection prevention. So actually I'm going to wait to dive into the detail when we look at those detailed quarterly reports. So I'm going to hand straight over to David for mortality, but clearly I'm happy to answer any questions that colleagues will have later.
Thanks, Lucy.
Thanks, Lucy. Yes, Jane alluded to another satisfactory month for mortality. The latest national data is always a bit confusing because we have access to both national and more recent local data. So the latest national data is actually 101.3 up to March, 103.1 up to March 23. But our latest local data, which will be more accurate, is actually 101.3. So and looking at the crude mortality graphs, we will lose some of the higher months. So I am hoping that Chizu will be able to claim a break of the 100 barrier when she comes in. I'd like to point out particularly the convergence of the expected deaths versus the actual deaths. So that's a reflection of the increased coding, in my view, the increased quality of the coding that we're doing. So that is making vast improvement. But you know, that's not just using figures to change real improvements. It's just accurately representing how we're actually performing. Perinatal mortality continues to be reassuring, and I'm relatively confident that we will meet the national goal to halve the stillbirth rate by 2025, which would be, will be amazing progress actually. And I'd also like to point out our no unexpected death goes unexplained programme. So this is just to ensure and reassure our colleagues in the public that every death that happens in our hospital is scrutinised in one of many ways, and increasingly, because of the rollout of our medical examiner service, that will be extended to all deaths in the county. So I'm really quite proud of that programme. Lastly, I'd just like to thank, or just introduce, he's not here, Chris Lakakis, who's going to be our lead medical examiner from next month, I think. But that's it for me. Thanks, Francis.
Thank you very much, David. Yes, I think we'll allow you to share the credit with Chizu if we get below 100 within a short period of time of your finishing your term of office. Thank you. Any questions or comments for Lucy or David? Nope. Okay, let's move on then. Andy, what are the highlights that you want to pick up your report, recognising that we're going to pick up the later in the agenda around the elective activity plans?
Yeah, thank you, Chair. It'd be remiss of me, even though James already mentioned about the industrial action, just to thank our operational and clinical teams over the last month in terms of managing that. And as James already alluded to, this week we've seen some real challenges in maintaining our elective activity, and unfortunately we had the highest number of cancellations this week, despite having to recover a number of cancer lists. Just moving on to our urgent and emergency care pathways and our quality improvement plan in value and patients' time programme of work. Despite all the challenges that we've had in the last month with industrial actions, we continue to make our changes to the acute floor, and in the second week in September we successfully opened and continue to ring fence our frailty same-day emergency care facility on the acute floor, which is staffed by a frailty coordinator, frailty ACPs, and has geriatrician support combined with virtual ward. And not only have we seen an increase in our virtual ward capacity because of that change across the acute floor, we're seeing on average, and it is still very early days, 9 patients a day going through our frailty SDEC, of which 6 are discharged home on average on the day, which is a significant reduction on bed days across our acute site. And we are starting to now see as well direct admissions bypassing ED from primary care, our ambulance colleagues and some of our community colleagues as well. Much more to do on our frailty SDEC, but a huge step in the right direction ahead of the winter. And our operational teams are continuing to look at our same-day emergency care capacity over this month, and we're looking to expand our medical and surgical facility, and I'll bring that back to board in due course. During the month, we invited the emergency care intensive support team to the Trust to review our urgent and emergency care plans, and overall it was a positive experience and a positive endorsement of the plans from the ESIS team. So much so that they actually stated there was strong support from the executive team in the development of our UEC plans, and recognising that we had challenges in terms of balancing our risk of elective and non-elective pathways, and that there was good plans in place and good levels of staff engagement. They also flagged some areas that we need to focus on, particularly a whole trust approach around each specialty and regarding their role in ownership in the urgent and emergency care pathway. And we're working that through at the moment with a refresh and review of our internal professional standards, both at ward level and cross-divisional level, particularly focusing on the emergency and emergency care acute floor standards. Some of the estates challenges in ED was recognised, and a recognition of some of the staffing and recruitment challenges we have across the acute floor, as well as the ESIS team highlighting that there was limitations to our SDEC facility because of the physical capacity, and as already stated, we're addressing some of that, and also some of the challenges in discharge to assess, which Jane has already mentioned, but there's much more we can do internally. ESIS are continuing with their support, and they're looking at supporting us with some demand and capacity work in our medical and nursing workforce, but also reviewing some of our bed capacity modelling as well ahead of the winter. In my report this month, I've also put in a summary of our bed occupancy and delayed discharges, and as I said, Jane's already alluded to some of this. What is interesting is I've compared months 1 to 5 of 22 versus months 1 to 5 of 23, and there has been a reduction in bed days for delayed discharges when we've compared the two periods. But again, there is much more to do ahead of the winter. But now we've got some agreement in our Better Care Fund ahead of the winter. We're looking at increasing our block booking for nursing homes, increasing our broker support, and increasing our adult social care across the weekends. We're continuing with our bridging team that supports our hospital at home team, and our D2A board has already started providing oversight and review of cross-system processes, and additional home first commissioning has been launched to bring down some of our D2A delays and reduce our overstayers. So much more to do ahead of the winter, particularly in some of our internal processes as well that need focusing and strengthening, but a lot's happened in the last month. Happy to take any questions.
Thank you, Andy. There really is a lot going on, isn't there? Any questions or comments for Andy? Nicola.
Hi, Andy. I read in the report that it's the busiest August on record, and probably if we were sat here last year, we probably said it was the busiest August last year on record. I just wondered if there's any themes, any reasons that we can clearly see why that's the case. Is it pressures elsewhere pushing people to us, or is it just sheer general volumes? And I'm also interested, is it in hours or out of hours? Do we see any pattern to what's coming through the door?
A pattern does change on a daily basis. There, our surge in demand is probably more unpredictable now than it was pre-COVID. We are seeing days when we're getting 240, 250 through the door, and then days where we're at 160. So our demand seems to be quite varied. The earlier parts of the week is vastly different from the latter end of the week, and then the weekends do fluctuate. In terms of that deep dive into what's driving some of that, we know our primary care colleagues provide more appointments than the rest of the country and do a really good job, and there is no evidence that it's primary care driving that. There is some evidence, and we are undertaking some work locally, whether the increase in our elective waiting list is driving some of our our urgent care attendances. Nationally, they have seen about a 15% increase in some systems because of their increase in their elective waiting lists. But we're doing some work on that. It is something, Nicola, that I don't truly have the answer to, but it is something that we are looking at.
Thank you.
Thanks, Andy. Ian.
Yeah, thanks, Andy. Some outstanding work being done by you and your teams in the face of challenges that are well rehearsed. The issue I wanted to pick up on was around same-day emergency care, where we're obviously doing a great job, which is helping not just with demand, but actually is a better outcome for patients as well. I picked up from the Chief Executive's report, he said he had a slight concern that same-day emergency care could become effectively an alternative pathway for outpatients. and I guess in reality it's probably quite difficult to monitor that. But I just wondered whether you had any view as to whether or not that is a feature of anything that we're seeing in SDEC and frailty SDEC in Wye Valley.
Not that I've seen, Ian. I mean, I think it is a balance between ensuring that we have enough space in our hot clinic slots in our outpatient sessions to deal with those patients that are returning from ED, but we haven't seen significantly a sort of bypassing of our elective pathways for any of those patients. But it is absolutely one to watch. I agree, Ian.
That's reassuring. Thanks, Andy.
Thank you, Ian. Just wanted to put on record a huge recognition of the impact of the strikes. So obviously primarily for our patients, the people who are waiting for care and treatment from us and having to have that delayed, but the enormous additional burden that it puts on staff to cover people's work and to plan work, unplanned work and all of the rest of it. So it is a frustration. Most, if not the whole of the board, like to be able to own a problem and fix it, and this is one that is outside our scope to be able to fix, and I think that's part of the anxiety and frustration for us all. So definitely echo Jane's comments that we hope for an early resolution so that we can all focus on treating people, our families and friends, as timely manner as possible. So please pass on thanks to colleagues across the system for holding the faith that we will get a resolution soon. People. Jeffrey, what would you like to pick out of your report?
Yeah, thanks, Francis. Well, we are still maintaining very good performance with most of our workforce, our key performance indicators, and we now have the lowest turnover rates over the last 4 years. So we definitely maintaining good performance with most of our KPIs. We continue to work actively with line managers in terms of managing sickness absence, and we'll continue doing that in a compassionate way over the winter months. We remain committed to equality, diversity and inclusion, and this month being Black History Month, we are promoting Black History Month across the organization. With October being the Freedom to Speak Up month, we are also working actively with the Freedom to Speak Up Guardian and our champions to try and highlight the importance of people speaking up and to raise the profile. So we're doing that across the trust as well in October. Next week is our annual Health and Wellbeing Week, where we have a series of wellbeing events for our staff being supported by a host of external organizations. So we're looking forward to that. It's something that just goes to reaffirm the importance that we place in the well-being of our staff. And finally, the staff engagement in touch campaign is now over, and there's a paper on that on the board agenda, and I'll come back to that. So all in all, I think those are the key things I wanted to pull out from our report, and I'm happy to take any questions.
Thank you, Jeffrey. Questions or comments for Jeffrey? No, all going the right way. We love graphs, but we don't love all graphs that go downwards, but when we're trying to reduce things, we do. So keep up the good work. But as I say, you get the credit for counting it. The teams on the ground get the credit for making it so. So thank you for that.
Yeah. Thanks.
Katie.
Thank you, Chair. So I'll take the report as read, but just pull out a few key headlines for colleagues, particularly in terms of the variance we're now seeing at month 5. So the report covers the period to the end of August, which is month 5 for us. And as Jane mentioned earlier, our financial position has deteriorated. So year to date, our deficit stands at £13.3 million, and that's around £1 million adverse to where we would have planned to have been at this point in the year. And we've talked in previous board meetings around some of those known financial risks, and they are putting increased pressure on delivery of our financial position. Just in terms of the makeup of that adverse variance in the year to date, so around £700,000 of that variance is as a result of where we've quantified variable elective income. So I've reported in previous months up until month 4 nationally, we were required to report elective income performance in line with plan, and from month 5 we've been asked to quantify that on a year-to-date basis along the rules that are set nationally around how to quantify that. From our perspective, we've seen really strong elective performance since June. We had a slow start at the beginning of the year. It's massively improved, and as Jane and Andy have referenced, our value-weighted benchmarks really well. So in August, just taking it as a month in its own right, we were at 109% of 1920. So although it's had an impact on our financial position in the year to date, and we do think from a mitigation perspective, assuming we can continue that strong elective performance, that should provide some mitigation to that in terms of the forecast position. The remainder of the variance relates to our cost performance, and primarily in terms of our CPIP. So we're under delivering in terms of where we'd planned to be. We're around about £2.3 million off where we should have been at this point in the year in terms of delivery of savings. And of course, focus does continue on really improving and driving efficiency and reducing cost. We've got a number of schemes from single department opportunities to trust-wide programmes and indeed system-wide opportunities. But it's important to note that capacity to progress some of those schemes has inevitably been hampered by lost operational capacity as a result of the work to plan and manage industrial action. Across the system, I reported last month, and it continues to be the case, that inflationary impacts are currently running greater than that was funded, and we're doing a piece of work across the system to make sure we're all counting that in a consistent way, and we'll report it from next month. What that does mean is that some of our opportunities to deliver savings are mitigating some of those run rate pressures rather than allowing us to improve that bottom line performance. So in light of some of those known risks and the year-to-date pressures, we're currently undertaking a mid-year review, and that will help us inform our forecast outturn assumptions, identify where we may need to put some additional support, and of course inform our planning for 24-25 financial year. From a capital perspective, no escalations to report this month, and just in terms of cash, conscious that we are a deficit plan and slightly off plan, we've reinstated our weekly cash management meetings and have those mitigations in place in terms of when we are likely to require national support in terms of access to cash, and we anticipate that will be in either December or January, dependent on that cash flow, but we're monitoring it really closely. Happy to take any questions, Chair.
Thank you, Katie. Any questions or comments for Katie? No, very comprehensive. Oh, Jane.
Sorry, just one. Other than observing how very odd it is to not report our elective underperformance for 4 months and then report it all in month 5, which seems like a very odd set of rules. How much of that 0.7 million broadly is related to industrial action underperformance on electives? Do we have a view?
It's part of what we're reviewing as part of the mid-year review, James. So we know the number of cases that we've lost through each of the industrial action periods, and we're just mapping that through in terms of the financial impact on the variance. So all of those elements of the variance will be more clearly described from month 6.
Thank you. We'll look forward to seeing the detail of that next time, Katie. Thank you. Kieran.
I think you're muted, sorry, Kieran.
Can I ask Katie, with reference to page 27 of the report and 52 of the overall package, when I look halfway down and I look at our current assets, I note that we've had a reduction of 24 million in the 5 months thus far this year. If I can make reference to the comment that Jane made earlier in the meeting, that the national financial position is deteriorating. And also noting that we've got a major capital programme, it's possible that we might not be able to access national cash. And I note that you've now got a weekly meeting on cash. Could I just ask you to update board members on the underlying cash plan before the next meeting?
I'm happy to do that, Kieran, absolutely.
Thank you, Kieran. Grace.
Thank you. Just picking up the comment I made in the chat. So in terms of the nursing agency cost, it looks like a lot of the cost comes from the specialist nurses, which are preferential agency can't always supply, and so we need to go out from that. So as a board, do we have any plans for finding more affordable specialist nursing cover in the long term? You know, things like kind of growing our own or encouraging the specialist trajectories and career training.
Lucy.
Yeah, in agency terms, when we refer to specialist nurses, and just for everybody's sake, I just want to be clear about what we mean by specialist. So we don't mean specialist nurses who work in niche specialties, providing care to particular clinical pathways. In agency terms, specialist nurses tend to be emergency department nurses, critical care nurses, children's nurses, special care baby unit nurses and midwives. Now, there are different strategies for trying to have a more sustainable local workforce for each of those. So in midwifery, maternity, for example, we're doing really well. Within critical care, we've got good recruitment, and therefore we can always recruit to turnover rather than vacancy factor to prevent agency use. But in other areas, so special care baby unit, for example, and other areas, actually there's a national shortage of those types of specialist roles. So it's really difficult for us to get ahead and have a local strategy for how we address that. But it is part of our overall nurse agency reduction plan to seize opportunities and do what we can locally, because none of us want to be going out to those expensive agencies. And interestingly, Katie and I were just talking yesterday around, we have a year left on our Master Vend contract, which is our current nurse agency provider, and certainly we might need to think creatively about what we do moving forward with future provision for nurse agency.
Thank you, Lucy. And for colleagues joining the meeting, we had a very interesting and energising discussion this morning at our board workshop about our organisational education, training, development and research strategy and how we grow our own and recruit to Herefordshire. Anybody who's joining us from elsewhere in the country, it's a really beautiful place to live and work, and we can find jobs in a whole variety of sectors if you'd like to come and join us. So people may not be aware of just the appeal of all of the things in Herefordshire. Nicola.
Hi, I suppose an observation as well as a future question, but we've always had an acute focus on finance and certainly under your guidance, Katie, but it's probably now that we're starting to see results in a way that we haven't seen certainly since the pandemic, and the finances and the direction they're moving in is in a position that we've not had for quite some time. So I can see there's a review going on in October to look at the second half. I know we were being asked to find extra savings in the second half that are now going to be greater because of the first half's performance. But I suppose it's just the observation that it is clear now that we're in a difficult position. When will we see sight of the October, and when is that review? And it would be good perhaps to have a little bit more time now looking at what that second half of the year might be, what those projections are, and what the reality of the situation is for the trust as we go into that second half.
Absolutely, Nicola. So we would expect to bring the outputs of that sort of mid-year assessment of stock take and therefore what it means for the forecast through as part of the standard reporting, and potentially then some further detail on that with board members outside of the headline IPR, so it will feed through probably in the December meeting rather than the November one, just because of the timing, and it's a group for boards, isn't it? But I'm happy to start to share the outputs of that ahead of the meeting in December, so it's not waiting until that point.
Thank you, Katie. And yes, definitely would like that. And it doesn't need saying that any members of the board who can give you support and guidance in that, just do reach out, particularly to colleagues with specialist finance expertise. Okay, I'm doing the standard. We're really running behind time now, guys. So moving into section 6 of the board items for approval. Some of these should be relatively straightforward. All colleagues will have read the papers in advance. So Jane, what would you like to particularly mention or pick out about the memorandum of understanding under 6.1?
Thank you. So firstly, really excited to bring this here. It's been work that's been going on for a very long time. It is 6 months late, and the reason why it's so late is because of the negotiations between the ICB and the local authority in terms of the commissioning of the Better Care Fund, which is a joint fund between the local authority and NHS. That now is agreed, and so it has now been delegated to the One Herefordshire Partnership. And whilst it's disappointing it's taken 6 months longer than we wanted it to get it agreed, I haven't heard of anywhere else in the country where this has been done. So we are very much at the forefront of this for a delegation of significant resources to a partnership that's based at place. So this is really exciting, as I say, although it's been a bit tortuous to get here. So it's not just the Better Care Fund. There are a number of other services which run primarily between ourselves and primary care, things like some of the enhanced services in primary care, things like spirometry, where obviously that's a link with our respiratory department, the work we do on virtual wards. So the resource that we have for that, it's for us to decide how we spend that resource between ourselves and partners. So really exciting we've got here. It's a whole number of things that are being delegated to us. Our intention is to do a really good job so that when we get to next year, there'll be even more that'll be delegated to us from the commissioning part of the ICB. So there's two MOUs. One is for the One Herefordshire Partnership itself. This has been a very agile partnership, learning by doing approach that's been working well for the last couple of years, but now we've got responsibility for some significant resources. There needs to be a bit more structure around that, and so that's what that's about. And then the second MOU is with the ICB, which talks about all of those services. So happy to take any questions, but I'm asking for authority for me to sign those both.
Thank you. I'll join you with your enthusiasm and excitement. Any other questions or comments for Jane? Nope. And if anybody is not happy to delegate that responsibility to Jane, will they please raise a digital hand? There are no hands, so get on and make it so, Jane. Thank you. But many congratulations and thanks to you and Alan and John and others for the tenacity of driving this forward. It's one of our strategic commitments is around integration, and this is a huge enabler for that. So we are anticipating significant benefits for the people of Herefordshire in the future. Okay, so moving on, 6.2, the Patient Safety Incident Response Plan. Lucy, is this you?
It is me, and it's here for approval. So just to recap, Broad have previously been updated on the requirements of the National Patient Safety Strategy, and this draft Patient Safety Incident Response Plan, so our local response plan, was presented to a board workshop in July in draft, and the plan that's in front of you today is based on the feedback from that board workshop, but also from other stakeholders that we've engaged with in the development of this plan. Clearly, having the Patient Safety Incident Response Plan is a really key milestone as part of the implementation of this new National Patient Safety Strategy. And just to recap for board colleagues and the public, the local Patient Safety Incident Response Plan, we must find something slicker to call it, replaces the Serious Incident Framework. There will be some national requirements that remain in terms of investigating never events, learning disability deaths, obstetric incidents that meet certain criteria, and we'll continue to investigate those in line with the national expectations. But what the local incident response plan is allows us to prioritise our investigative resource and respond to incidents in a way that we see fit. The plan's been developed by triangulating multiple data sources and local intelligence for Wye Valley Trust in terms of where we've got common themes, where we've got themes coming through incidents, complaints, serious incidents, claims and other data sources. And that's informed the plan to say, actually, these are the areas where we need to focus some of our investigative resource to maximise learning and improve patient safety. The plan, as I say in my exec summary, has been consulted widely, both with colleagues sitting around our clinical audit and effectiveness committee, patient safety committee, indeed our patient safety partners. And just to remind colleagues, our patient safety partners are members of the public that have been recruited to support our patient safety agenda, and they've been fully engaged within the development of this plan. We've shared it with ICB colleagues because ultimately the Integrated Care Board are required to sign off our local response plan, and we presented it to Quality Committee last month, who recommended submission to board for approval today. Clearly, the development of the plan, the implementation of the plan is going to be iterative. You know, the development of a patient safety incident response plan is new for the whole of the NHS, as is the new National Patient Safety Strategy. So it will be subject to regular reviews to ensure that we are focusing our resources on the priorities that we face as an organisation to maximise learning and improve patient care. That's all I wanted to say. I'm happy to answer any questions or take any questions away that I can't answer. Over to colleagues. Thank you.
Thank you, Lucy. And as you've clearly articulated, we have seen this in many different forums, and so this isn't new to anybody, I hope. Ian.
Yeah, they're observations more than questions, Lucy. And the first one is it's a framework, it's a new process, and it would be very easy to see this as one process replacing another process. What I am pleased about, and we had a discussion about this at Quality Committee, is actually we absolutely have got our focus on improving quality of care and patient safety, and if we didn't, we'd be missing the point. And I'm really pleased there's actually genuine enthusiasm for this because of the potential it has to improve the work we do to improve our quality and safety of care. So I think it's important actually to particularly for members of the public, this is about improving quality and safety of the care that we provide. And then the second point, which actually you did touch on, is that actually this is new. So as it says in the report and in the document, we won't get everything right straight away, but actually we're going about this absolutely in the right way, I think, and we will learn to some extent by doing. And we need to accept that as well. So credit to the people who developed it.
Thank you, Ian. Agree with all of that. Any other questions or comments? Nope. Anybody who's not happy to approve it, please raise a digital hand. No digital hands raised, so approved. Thank you, Lucy, and many thanks to all of your many colleagues who've worked really hard to make this so. And as Ian said, it is iterative. We will learn by doing and refine as we go along. Okay, so moving to the board assurance, self-certification, protecting and expanding elective capacity, talking of things that don't flow off the tongue particularly well. Andy, what would you like to pull out and what are you seeking from the board?
Thank you, Francis. Yeah, apologise, that wasn't my title. That was a NHS England title, so they can take the blame for that one. Yeah, I know the board has previously been cited on this. With Jane emailed it round to board members a couple of weeks ago, and I apologise that that was a bit short notice on that, but some of the dates were moved by NHS England regarding the return. So this basically was a letter that we received, or every trust received in August from NHS England, around the assurance that we are driving our outpatient recovery at pace. And it does link really neatly into what Jane alluded to in Glenn's report regarding our getting it right first time, faster, further work. This links absolutely neatly into that piece of work. There's 12 sort of key areas or key lines of inquiry that required assurance, from how we're managing our waiting list validation, our patient access policy, down to, as Jane's already alluded to, patient initiated follow-ups, reducing DNAs, increasing special advice, and more importantly, transformation in outpatients, particularly on follow-ups. I think there's 10 areas which we are confident that we will deliver on. There's 2 areas that I would just like to focus on that we are including as amber in the report. One is around achieving the 25% reduction in follow-ups in year. That is a significant challenge for us. We started our position pre-COVID in a really challenged place in terms of our follow-up patients past their see-by date, but all the work in the Getting It Right First Time Faster Further programme, or a majority of the work, is focused on how are you reducing our follow-ups, from patient-initiated follow-ups, increasing our validation, and looking at the playbooks that Jane had already alluded to in terms of benchmarking ourselves, not just across the foundation group, but the other 25 trusts within the Faster Further programme, and how we can work differently. There's still lots to do there on reducing down to 25% down on our 1920 levels. The next area of concern is actually the transformational opportunities themselves. They are ongoing. They are on part of the GIRF Getting It Right Faster Further programme, and we have got additional support through our transformation team, focusing on those opportunities and working with clinical teams to ensure that we are working across the Faster Further group to look at best practice or what we can implement in Wye Valley. And there are various areas, particularly in rheumatology and dermatology, that we are sharing across that Faster Further group. The reason I put it as amber is because as a trust we are focusing on 7 key specialties. Although we are working through the playbooks in all of our specialties, there are 7 specialties we are particularly focused on before April 24, and those are the 7 specialties with the highest risk of 65-week patient breaches, or patients waiting greater than 65 weeks for the start of their elective treatment at the end of March 24, beginning of April 24, and those are T&O, gynae, ENT, neurology, cardiology, gastro, and dermatology. So we are confident that the transformation work will move significantly in those areas. Some of our other specialties where there isn't at the moment a significant 65-week breach is in, if you like, phase 2 in terms of that transformational support. So I'm seeking approval that has already been submitted to NHS England, but just for governance and assurance here that the rest of the board members are happy or have any further questions. We are at the next Foundation Group board meeting in November doing a deep dive across the Foundation Group on our GIRF Faster Further programme, and looking at the learning and opportunities across the group that fits in with this piece of work.
Thank you, Andy. And yes, a helpful reminder that the approval was delegated outside of the meeting through the executive colleagues and to the non-execs, so everybody's had a chance to comment. The timing of this meeting and the change in the deadline meant that we had to do that virtually. So any particular questions or comments for Andy? No. So if anybody wants to rescind their previous approval, please raise a digital hand. No hands raised, so approval. Thank you, Andy. And it's always good when the work that we're already doing then fits with the national expectations. So love it when a plan comes together. Thank you. Okay, so moving on, audit committee terms of reference. Erica.
Thank you, Chair. Not many changes to report really to the terms of reference. They have been through the audit committee in September. There's the inclusion of the local counter fraud specialists as key attendees at the committee. And there's the only other change reflects the change in governance around the quality account, with the audit committee not being required to review and approve those accounts, but seeking assurance that they've met the reporting requirements. Other than that, there's no change.
Thank you, Erica. As you say, it's been through the audit committee anyway. If anybody is not happy to approve, will you please raise a digital hand? No hands raised, so approved. Thank you. And the board and committee dates for 2024.
Sorry, Jane.
Oh, sorry, Jane.
Yeah, just a quick one on that. Obviously our audit has been delayed the last 3 years, so it hasn't quite worked, but I'm assuming that isn't going to be the case next year. Our July end of year board, usually we use that board workshop time for audit committee. Will that be the plan for next year?
So looking at the dates, the only dates that are really fluid are those July end of year dates. and I think that's why they're in red.
It may be a board with a workshop, or it may be signing off the accounts.
Yes, I think learning from the past 2 years, certainly it's having the flexibility, and we would hope to firm those up as soon as possible.
Katie?
Yeah, just to add to that, so we're just awaiting the national timetable to be published in terms of national expectations around the audit process and submission dates, and then I think at that point we can take stock and confirm these dates.
So with that proviso, is anybody not happy to approve the board and committee dates for next year? Approved. Thank you, Erica and colleagues. Okay, so items for noting and information, and I would like to take item 7.4 before the rest of this section, if I may, and I think that we've been joined by Salma Ibrahim, who's our clinical lead for OBS and Gynae. I can't quite see you yet, Salma, but I believe that you might be with us.
I am around, yeah.
Excellent. Welcome to the meeting. Thank you for making time in your clinical schedule for that. And Lucy, would you like to introduce the maternity CQC item?
Yeah, I'll take the CQC report first, and then I'll do the maternity quarterly report, if that's okay. And as you say, we're joined by Salma Ibrahim, who is a consultant obstetrician and clinical director for maternity services. I'll cover both reports, but Salma will happily answer any questions that colleagues may have. So just to recap, all maternity services have been inspected as part of the national programme on the back of Ockenden, and we had our one-day inspection, which was an announced inspection, which took place in June. The national programme only reviews the safe and well-led domains of maternity services and doesn't look at the other domains. And the report was published yesterday, hence the late submission into the board pack, because we couldn't include it in the board pack until it had been formally published by the CQC, which happened at 8 o'clock yesterday morning. It's a really great report, is where I want to start with. In relation to the safety domain, whilst the safety domain has remained, it requires improvements, which is the same as it was for the last time the service was inspected. You can see when you read the content of the report and compare that to where we were previously, that we have certainly made improvements in safety since the last inspection. And those areas where the report highlights that we've got areas for improvement, there were no surprises there for us, which is where you would want to be, and plans were already in train to address those matters. And you can see that there's very few things for us to put right in the context of the report when you turn to the back of the report with the must and should do actions, which are really fairly limited in number. What's really pleasing to report is that the well-led domain improved from requires improvement to good, which is excellent news, and therefore the overall rating for maternity services is also good, which is an improvement from requires improvement. Given the limited number of must and should do actions, there's a very small action plan that has been developed, and that's been presented to Quality Committee last week and will be reviewed through Quality Committee until all those actions are concluded. But I'm really hopeful they'll be concluded very quickly, and we'd be well on the path on our journey to good and outstanding, which is where we want to be. And finally, from me, I think it's just to say that the CQC report and the achievements within it are down to the hard work of the multidisciplinary team, that's clinical staff and management staff within the service. So well done to them for receiving such a good report and the hard work and leadership that team have put in place. I'm happy to answer any questions, and I'm sure Salma will be too.
Thank you, Lucy, very much. And your very measured and professional representation of that is accompanied by huge thanks and congratulations from the whole board. This is a really significant outcome and commendation to the services that we provide for women and families in Herefordshire and Powys. So absolutely echo that, and to Salma. Amy Symes, who is our head of midwifery, is had unfortunately booked annual leave, so isn't able to be with us today, but I'm sure Salma will feed back the board's thanks and congratulations. The team are very ambitious to be providing the best, safest care that we possibly can, and it's very good that the external assessment of that has recognised the hard work and commitment that everybody has made. Any questions or comments for Salma or Lucy on the CQC report? Salma, anything you'd like to say?
Thank you very much. I think congratulations for the entire trust, I think, board and everybody. We're quite fully committed to implement any improvement that they have suggested, and certainly will take this as quite serious, and we will implement their recommendation to improve our service. So I think it's well done for everybody, for the obstetric, the nurses, the anaesthetist, everybody on the maternity, midwife, certainly everybody. Thank you.
Well said. Thank you. Thank you, Salma. Ian, did you want to comment?
Well, partly I wanted to ask Salma or invite Salma to comment. So you you did that, but I think simply just to endorse what you've said. This is a good, obviously a good outcome. Maternity services across the country are under particular scrutiny at the moment, and there's some well documented challenges and failures in services. So we should be pleased, yeah, very pleased that actually we've got a good assessment. And what we know is we won't be complacent. Actually, the journey starts towards outstanding.
Absolutely, thank you.
Now, so yeah, but a really good foundation on which to build. So thank you, Salma, to you and your team.
Maybe. Thank you.
Thank you. Well said, Ian. And I know through the quality committee you will keep tabs on the delivery and the assurance about the experience and outcomes. Thank you very much. Sam, have you got 5 minutes to stay for the next item? Lucy might want your input. So if we can go back to the normal agenda, so 7.1, Lucy, the Maternity Services Quarterly Report.
Yeah, certainly. And I'm covering this as the chair alluded to. Our Associate Director of Midwifery is currently on holiday in Sorrento, so I'll cover this today. The things I want to highlight from the report is just that we continue to have really good, robust management of incidents when they occur and events that happen that require review. Those are reviewed in line with national requirements, but also in conjunction with our local maternity neonatal system colleagues to ensure that we've got supportive peer scrutiny and objectivity external to the organisation when events go wrong, to ensure that we maximise learning and improve safety and experience for our service users. It's really pleasing to see that we continue to have a low number of complaints reported into the services, low numbers this month, this quarter, but also in previous quarters. What the service have recognised actually though is that some of those complaints that end up in the formal process could be managed informally, and therefore the service are introducing debrief and birth afterthoughts to try and prevent some of that feedback turning into a more formal process. As part of the Ockenden publications, all maternity services are required to have what are called insight visits, and the insight visits are undertaken by the local maternity neonatal system and also by regional colleagues. And what they do is they look at quality, safety and engagement, and they provide feedback for improvements. And our next insight visit is scheduled for the 18th of October. So we look forward to welcoming both regional and LMNS colleagues to that insights visit. It's really pleasing to note in the workforce section, we did a huge recruitment campaign for midwives in the early summer, and that yielded a large number of midwives some have already joined us and the remaining are due to join in the next few months. That's left us with a really small vacancy factor within the midwifery workforce, and we're hopeful to have filled all of those vacancies by the end of this financial year. In relation to CNST 10 standards, board colleagues will recall we achieved 10 out of 10 standards last year, which is fantastic, and work is progressing to ensure compliance with 10 standards this year too. We're in year 5 of the scheme. The scheme changes each year, and the biggest focus at the moment is around the standard that relates to the Saving Babies' Lives Care Bundle version 3, which has significantly changed and therefore means we need to go to more focusing around that. We're really positive that we'll achieve all 10 standards and Saving Babies' Lives version 3, because we were seen as an exemplar site in our implementation of Saving Babies' Lives version 2, which is really positive and good news. And then finally from me, just in relation to the CNST 10 standards, we are required to have board level safety champions. I'm the executive safety champion and Francis Martin is the non-executive safety champion. Part of our duties as safety champions, and we have many duties, but one of them is to ensure that we meet on a regular basis with the clinical leads, so that's the doctor leads and the midwifery and nursing leads for neonatal services and maternity services, to support them with resolving safety issues or concerns that they have and offering board level support. And Francis and I met with the maternity neonatal leads last week, and we have agreed this month to support with resolving the ongoing issues around maternity triage, which is a recognised risk which we have a plan to address, and we're hopeful to have a start date for the next phase of that work to commence soon. We've committed to support the neonatal unit with their stage 1 assessment for breastfeeding, or the baby friendly assessment process, which is supporting women to breastfeed where they choose to do so. We'll clearly have offered our support both in terms of the insight visit on the 18th of October and any subsequent findings from that visit. And I'm really pleased to say that our neonatal colleagues, obstetric colleagues, maternity colleagues didn't raise any safety concerns that require the board's attention, and Francis and I are due to meet them again in the back end of this year, in line with the CNST 10 standards. Happy to take any questions or bring Salma in for any questions also. Thank you.
Very comprehensive, helpful for Lucy. Thank you. Any questions or comments for Lucy or Salma? No. So again, it's a really dynamic situation, a very cohesive team, very clear about the expectations, and as Ian said, in the context of the appropriate public scrutiny and questioning of maternity and neonatal services, we are all of the board, but particularly Lucy and I as the board safety champions, will very much want to hear from women or families if they have any issues, and we are making sure that our contact details are available and broadly published should any members of the public wish to contact us directly. So again, thank you to Salma. Please pass on our thanks and congratulations to the whole team, and we'll see you very soon.
Thank you very much. Okay,
we
bye now.
Do stay for the rest of the meeting, but I dare say you don't need to.
Thank you.
Thank you. Lucy, back with you, please, for the patient experience report.
Yeah, I'll be as brief as I can be. I'm conscious of time. So quarterly report, we continue to roll out text messaging, and we continue to see a really good response rate above the national average for family and friends feedback through that mechanism. We did notice low response rates within our integrated care division and highlighted that that was to do with the fact that we hadn't got current mobile phone numbers logged on our system. So we're working hard to address that so that we can improve our response rates in the integrated care division. As I say, the vast majority of responses to the family and friends texting service is really positive, but clearly there's some really helpful information and feedback where we could do better, and the Patient Experience Committee are focusing on that. We've set up an improvement group to deal with patients' property, which is an issue nationally across the NHS, but particularly here at Wye Valley. And it's not necessarily high value items that go missing, but it's those very important items for our patients, such as hearing aids, false teeth, and things that are really important to them. So we've set up an improvement group to look at that. I alluded last month to a high volume of complaints throughout the months of June and July, and there's a bit of detail in the report around the themes from those and which areas they were within, which was women's and children's, ED and the head and neck specialties. Clearly that higher volume of complaints has led to a dip in response rates to complaints, but I'm pleased to report that the number of complaints coming into the organisation are back within normal limits. We're not seeing those high numbers that we saw in June and July, and therefore our response times are improving. Also, Quality Committee received the results of the Emergency Department, the Inpatient Survey and the National Cancer Surveys at its meeting last week. And just very briefly, in relation to the Inpatient Survey, actually a really good overall response rate compared to other trusts in England. We're about middle of the pack, which is not where we want to be, but that's much better than where we were previously. And clearly we aspire to be better than middle of the pack. There are some stubborn issues that for the past few years we've not been able to progress or make improvements in, and I'm really pleased to report that those stubborn issues, which were general communication, discharge and trust and confidence in doctors and nurses, is much improved in this inpatient survey. We do have some areas for improvement, particularly around communication around surgical procedures, timeliness of discharge medications and hydration, and we have work streams for taking those things forward. Discharge medications have always been a challenge for us and will continue, are likely to continue to be a challenge given the difficulties with recruitment and workforce in our pharmacy department. The ED survey, I mean, we can see in the pack that ED attendances, time in the department and time waiting for admission has significantly increased year on year, putting pressure on the department. And that has led to disappointing results for the emergency department survey. And the departments have pulled together an action plan focusing on communication, capacity and demand, and privacy and dignity. And you heard Andy and Jane allude earlier to the changes that we put in place around the urgent and emergency care pathways, particularly frailty SDEC and other changes. And we're hopeful that those larger schemes will help drive improvements in overall patient experience within the emergency department. And then finally, the cancer survey. We always do really well with the cancer survey, and yet again, a good suite of results with that. Some areas where we need to improve, not across the board, but in some cancer specialties, particularly around point of contact for patients, care planning, and what to expect around radiotherapy. That's it from me. Happy to take any questions.
Thank you. We've had extensive scrutiny of this elsewhere. So any particular points to pick up here, Jane?
Yeah, one comment and just one question. So first of all, the comment is I think you should say it's a generally improving picture, ED aside, and we understand that and need to drive further improvement. But so that's good and to be celebrated. You say though much more improvement to come. In terms of driving that improvement, have we got the feedback, both the qualitative and the friends and family scores feedback down to ward level yet? So individuals can own their own results?
We absolutely have. We identified a training need with individuals not recognising how to access the information. We've addressed that, so individuals should be able to pull that information off and indeed triangulate it with other sources of feedback.
Good. Thank you very much. Noted. Thank you very much, everybody, for all their hard work on that. Patient experience reporting is the benchmark of everything we do. There's no point us congratulating on what we're doing if that doesn't translate into reality for our patients. So a hugely important measure of our effectiveness. So the Infection Prevention Annual Report, and again, this is you, Lucy. It's been to Quality Committee, been well received there. Is there anything particular that you're asking the board to note that hasn't already been discussed?
No, not really, because as you said, the report's not new. So we have a quarterly report through to Quality Committee. We have monthly key performance indicators on infection prevention and control that come here. So there's nothing new. This is just a culmination of the quarterly reports and the key performance indicators into an annual report, which is a requirement of our contract. I think the things I would want to highlight is that we were, if you remember, an outlier for our C. diff rate. And by an outlier, we were in the bottom 3 trusts in the country. And therefore, it's really pleasing to note that we finished the end of the year below the trajectory that NHS England had set us. So that is good news. Where we didn't meet our thresholds, we know where we need to make improvements, and that's particularly around catheter care to try and reduce some of those gram-negative bacteremias that we've seen. The investment in the NHS cleanliness standards happened in the last year, and that investment led to an extended workforce around cleanliness and monitoring, and we've seen improved star ratings and standards of cleanliness in more recent quarterly reports. As colleagues know, we've been under intensive support from NHS improvements around cleanliness and infection prevention, and they're due to come and re-inspect us in November. The rest I'll take as read and happy to answer any questions.
Thank you. Any particular questions or comments for Lucy? No, noted. Some good news. Keep up the good work. Okay, 7.5, in touch staff engagement. Jeffrey, you and Jane both made reference to this earlier. We've read the report, seen the, I really like the simple, you said we are, we will. What would you like to commend or ask the board to particularly take notice of?
Well, I guess the the paper just outlines the steps that we will be taking to enhance the culture and the working environment within the trust, because we know that in the health service, it's now widely acknowledged that in order to enhance the patient experience, you have to enhance the staff experience. And how do you enhance the staff experience? You do that by engaging with your staff. So that the paper just outlines a comprehensive engagement campaign we ran over the summer months with over 1,000 plus staff engaging. We looked at 4 key areas as outlined in the paper, which are aligned to the staff survey and the NHS People Promise, but it gives us the local intelligence based on what is really relevant to staff within Wye Valley. So the posters just outlined the actions we're going to be putting in place, and we have the monthly staff engagement group just so we can make sure that those actions are being implemented. So just to give you a sense of what we've done so far, and I think in future we'll come back and just update the board on how those actions are being implemented across the board. So that's really all I wanted to cover. The posters speak for themselves. Happy to take any questions.
Thank you, Jeffrey. Any questions or comments for Jeffrey? Nicola.
Just want to say well done, Jeffrey. This isn't something we've had before because it's new, and it's been a lot of hard work from you and the team. And I was really pleased to sit in some of the sessions in the summer and see what that discussion was, be it being led by leaders within teams. And so I'm keeping everything crossed that you get much more response, because I really think you put the work in, and I hope it pays off. So well done.
Thanks.
Second that. Thank you, Nicola. Ian.
Yeah, would endorse that. Thank you, Jeffrey. And I know this has been well received from conversations that I've had with staff when I've been out and about. The one question I wanted to ask was around support for overseas nurses. There are a couple of comments in the feedback, and clearly these are a kind of hugely important staff group now, doing a great job for us, and people who've not only come to a new job but actually come to a new country and settling here as well. And what I was interested in, and you may not know the answer to this, was about the wider support as a Herefordshire community that we provide to people who come and settle here. Obviously, we have duties as an employer, but I was reflecting the other day on the extent to which actually all those other things which help people feel at home in the place that they live, which then contributes to kind of how able they are to, or their overall satisfaction with the job that they do. And do we engage, do you know, with other services within Herefordshire in terms of the support and welcome that we provide to our overseas staff?
We certainly do, and we have pastoral offices within the HR team and clinical education team. But in addition to that, we are relaunching the staff diversity group. So we are developing an international staff charter, so charter for staff. We are also now engaging with some local community groups as well. So they will be on board when we relaunch the staff diversity group end of October. So there's definitely things that we can do more. And through the pastoral care offices, we've now got in touch with some community groups, and we're going to be working with them as we go forward.
Thank you.
Good to hear. Thank you. Lucy?
Yeah, I think Jeffrey's mainly covered what I was going to say, but the pastoral support officers, and you will recall at the AGM we celebrated receiving the Pastoral Quality Award from the region, which sort of is wider than just our response as an employer. It's around how we link them to community groups, make sure they've got bank accounts, all of those things which we excel at, and that's why we're seen as an exemplar site. I mean, there's always more that you can do, but we're sort of leading by example, I would suggest, Ian, on that front.
Excellent, that's good to hear. Thanks, Lucy.
Thank you, Lucy. So commend this work, the more and more of it, and if any board members can help you, your colleagues will know that we are increasing the linkages between non-exec directors and specific sections of the organisation, but that doesn't mean that we're not all available to go anywhere and everywhere. So wanting to support staff and hear on the ground what it feels like on a day-to-day basis at every opportunity. Thank you. Okay, some committee summary reports just to receive. The first is the Integrated Care Executive from September 23, and of course I chair that. Oh, Erica.
Thanks, Chair. I just wanted to sort of expand on the detail about the discharge to assess board, because the just to clarify what's written there or make it clearer. So the main two outputs from the recent workshop were how to implement the revised process and how to understand the proportions to be allocated to each pathway and how best to resource. I think what's written there is probably not articulated as well as it should be.
That slight amendment noted, and Val will, I'm sure, add to the minutes. Thank you. Any questions or comments in relation to the Integrated Care Executive? No, thank you. The Quality Committee, the 31st of August, Ian.
Yes, thank you, Chair. The only point I wanted to draw the board's attention to was the concerns that we had around Mental Capacity Act and deprivation of liberty safeguards, which is an issue for us for those patients with limited mental capacity or who need the protections of the deprivation of liberty safeguards. We've put a lot of effort into this and a lot of training's been done on raising awareness. What we were disappointed about was we've been anticipating that audits would have been done in order to demonstrate the effectiveness of that, but unfortunately due to staff vacancy we've not been able to complete that. What I am pleased to report is that the new member of staff has now started, so we hope to be able to report back with some assurance next time around.
Noted, and we'll look forward to that next time. Thank you. Lucy.
Just on that note, sorry, we are back down to one member of staff in the team, so I don't think that audit that we anticipated that we hope to get on top of is going to happen soon. We clearly need to be able to do that audit, but the team is very limited in number due to an unanticipated absence in that team, so they're really stretched. All they can do at the moment is operationally deal with safeguarding cases and responding to those.
Okay, noted, and not necessarily for a response now, David, but we know that our junior doctors all need to do audits of various things. Maybe this could be an opportunity for somebody. I'll leave you to contemplate that. Okay, Audit Committee, the 15th of June, Nicola.
Hi Francis, it was very year-end orientated, so you'll find that most of the stuff is related to year-end, which we've now put to bed. The only other thing of note I would put in there is we're now starting to include some of the financial and other governance information linked to the ICS, and I think that will probably grow going forward, particularly as we try and align ourselves to see what we can all work together on. So I would say expect to find more of that.
Noted, thank you very much. And the Quality Committee of the 27th of July. And
nothing to add, Chair. Happy to take any questions.
Any questions for Ian? No, okay, jolly good, thank you. Any board members got any other items of business that they would like to raise now? Can't see any hands. I think we do have some questions from members of the public. Erica, is that correct?
Yes, we do, Chair. The first one is around tissue viability. Does WVT employ a full-time tissue viability nurse for the county hospital?
Lucy, I suspect that's you.
We do. We have 2.4 whole-time equivalents within the tissue viability team supporting tissue viability, and that team work in an integrated way across the acute site and within community services. And that 2.4 whole-time equivalents is actually 4 people. So we've got more resource to spread across our services.
Thank you. And the next question was, does WVT employ a tissue viability nurse to support the community nurses and community hospitals? And then, does WVT run refresher updating education training for its staff upon pressure ulcer prevention? How regular is this refresher training? Is it mandatory? Are healthcare assistants required to complete such training?
Yep, certainly. So I think I'd answered the community tissue viability nurse in terms of the team cover both community and acute. In terms of training, so all healthcare assistants receive what's called care certificate or fundamentals of care training at the point that they join the organisation, which includes tissue viability and pressure ulcer prevention, moisture associated skin damage and other skin integrity training. And clearly registered nurses, allied health professionals and others receive that as part of their core pre-registration training when they're at university. We provide the national online training for pressure ulcer prevention and tissue viability, which is for all staff. It's not part of our mandatory offer, but it is recommended that all relevant staff in a clinical setting should undertake that training. And that's just because if we made all of the training that we thought all of our staff needed to do mandatory, it would take days and days and days and days. So it's not mandatory, but that's not to say it's not important and staff aren't encouraged to complete it. And we know that compliance with that is at a good level. On top of that, we offer bespoke training to our workforce, particularly those tissue viability champions that are based at ward and clinical level, because we provide them with bespoke training so that they can provide on-the-job training and support to their colleagues. We also offer tissue viability as part of our clinical practice weeks, which is where we take training to the ward and clinical areas and provide bite-sized training there. And tissue viability is on a rolling programme for that. And as I say, we've got tissue viability champions, which are there to provide advice and support in clinical areas.
Thank you, Lucy. Very comprehensive.
And then the second area of questioning, Chair, was around stroke patients. Mechanical thrombectomy is a fairly new and very effective treatment for stroke patients. Does WVT offer or have any plans to offer mechanical thrombectomy to its patients on a 24/7 basis? If the answers are negative, then, as time is of the essence for such treatment, will WVT transfer appropriate stroke patients to hospitals that do offer such treatment?
A very important line of questioning. David.
Thanks, Erica. The short answer is no and yes. The longer answer is, if I could just explain the pathway. If you have symptoms of stroke, you become, it's an emergency, it's a brain attack. You would call 999, come into our ED, and be scanned within an hour. As long as you met various criteria and it showed that you were suitable for thrombolysis, so that's dissolving the clot that's caused the stroke, you will get thrombolysis in Wyre Valley in the ED department. Should that scan also show that you've got something called a large vessel occlusion, so an LVC, an LVO, which means it's amenable to being removed mechanically, so with wires, then your scan will be sent to our thrombectomy centre, which is UHB and will remain to be UHB. And the interventional radiologist at UHB and the stroke physicians will decide whether that clot is amenable to removal, and you'll be transferred. And as long as you're transferred within 6 hours, that intervention is, as whoever the questioner is correct in saying, highly effective. We've got a helicopter retrieval pathway as well, and as an anecdote, we had a patient with such a clot that was amenable for thrombectomy in our ED department. UHB at exactly the same time also had a patient with a clot that was amenable to thrombectomy, and our patient got to thrombectomy suite via helicopter before the UHB patient did. So it's as effective as we could make it. The other thing is actually overall with regards stroke, Erica, is our SNAP audit is the best in the so that's a quality audit done every month on our stroke services, and it's the best in the West Midlands and has been for several months.
Thank you, David. Very reassuring. And yes, stroke is a hugely anxiety-raising issue, rightly so, for the members of the public, and as David has described, is one of the things that time is of the essence. So if you have any concerns, do all the things that the literature tells you to do, and we will take appropriate action to reassure people. Our systems talk to each other, and what David just described is that we have effective pathways that can get people to the right level of care. It's not, because of the small numbers, it isn't something you would expect to be providing in district general hospitals across the country. It is a very specialist service, but flying people to that care is extremely efficient and a well established pathway. Thank you. Any other questions, Erica?
Yes, Chair. The third area of questioning is about live face-to-face public board meetings. In August 2023, the board were asked, does WVT board intend to return to live face-to-face public board meetings? If so, when? The answer, which was in our September papers, was the chairman advised that the meeting today is being live streamed on YouTube. Lockdown has enabled more productivity and ecological benefit of digital meetings. Digital meetings allow more inclusion for those who are less mobile and geographically isolated. There is some further detail from the questioner about the accessibility and the use of internet by the population, specifically in Herefordshire. But they summarise with, I would suggest to WVT that to be truly inclusive, public board meetings need to be both face-to-face and live streamed, as Herefordshire Council meetings are. Apart from the chair, I would be interested to hear the views of other board members.
Thank you, Erica. And of course, our responsibilities as public servants is to be accountable to the public, and we want to make sure that we are doing that. So, Jane, thoughts from you?
Yeah, so I think it's a good point, and I think it's something we need to keep under review all of the time. I mean, there's no doubt that we reach more people in this way, and I take all of the points in terms of not everybody is digitally included, but equally not everybody's got access to transport. And when we've met face to face, generally we have between 3 and 5 people, generally the 10 people who same people who are always very welcome, but generally the same people who actually attended. So we are much more accessible now than we ever were. We have to get the balance right, but digital definitely has to stay a part of the way that we do this in the modern age.
Thank you, Jane. Erica, do you have the figures of people who do access the recordings and the streaming of our meetings?
The September board had 63 views. Our AGM had 720 using YouTube.
Thank you. So reassuringly significant numbers. Any other board members have any comments that they'd like to make? No. So again, as Jane says, we will keep it under review and want to make sure that people can observe and scrutinise the work of the board, and also feed questions and comments in, and would encourage people to do that. And if they don't have personal access to do that, there are local facilities and organisations that can enable them to do so. So hope that that will help people to feel that we are suitably accountable to the members of the public. Any other questions, Erica? No.
No.
Okay. Thank you. So at the beginning of the meeting, I did make reference to the fact that David Mowbray, this is his last board meeting with us as our Chief Medical Officer. I'm not going to embarrass David too much by saying that he's the best since sliced bread, albeit I happen to think that sliced bread's not very good for you, and David's been very, very good for us. So David joined the Trust, I gather, in 2001 as a consultant obstetrician and gynecologist, and took over as Chief Medical Officer in 2018. So I hope, David, that you feel that you have enjoyed and benefited from your time working with us in Wye Valley. On behalf of the board and also the people of Herefordshire, a huge thank you. You have made the most significant contribution in many, many ways. We've talked about the shimmy, but your impeccable leadership, your commission, your compassion, your commitment to making things better, and certainly from my perspective, joining the board, your curiosity, your humility, your humour, and your absolute commitment to something that I feel very strongly about, which is the Nolan principles that I think you are a prime example of exhibiting. So thank you for that. As I say, there will be a chance for the board to say thank you in public when we see you shortly, but a huge thank you from the whole board.
That's extremely kind of you to say. You brought a tear to my eye, Francis, but it's been a pleasure working with you all. Really, the last 5 years have been the most fulfilling of my whole medical career. So I can only thank you all.
Well, that's very, very good to hear. And we're also saying goodbye to David's deputy, Dr. Robbie Deedy, who's leaving us to pastures new as Chief Medical Officer for Birmingham Community Healthcare Trust in due course. But very, very pleased, as I said at the beginning of the meeting, to welcome Chizu, who will pick up the mantle and continue to make a huge contribution through the board on behalf of our medical colleagues with all of the wide agenda of things within her remit. Any other final questions or comments from anybody? No, in that case, I'll draw the meeting to a close. Thank you all very much. Can I suggest that we take 5 minutes and then reconvene to discuss some items